This is Randy Schell, and I'm making a podcast entitled Anesthesiology Gaps in Knowledge 2014. This is part of the University of Kentucky Department of Anesthesiology didactic curriculum. The gaps in knowledge from 2015 and 16 are on separate podcasts. What are gaps in knowledge? They are questions that a majority of residents answered incorrectly on the annual in-training examination. And in this case, from the year 2014, the American Board of Anesthesiology publishes a list of these topics in an attempt for us as learners to make sure that we are both teaching and learning these concepts that have been difficult to some. The first gap in knowledge from 2014 was that patients who are receiving 5,000 units of heparin BID for more than 5 days can develop a decrease in their platelet count. And according to the American Society of Regional Anesthesia guidelines, a platelet count may be indicated before removing an epidural catheter in patients who have been receiving subcutaneous heparin for this period of time. On the graphic on the far right, you can see that subcutaneous unfractionated heparin, if it's given for greater than 4 days, some will recommend doing platelet count prior to removal of the catheter. The number 2 gap in knowledge for 2014 was that the Society for Ambulatory Anesthesia guidelines for the management of postoperative nausea and vomiting do not recommend metoclopramide or Reglan as an antiemetic for a patient who has received prophylactic ondansetron intraoperatively. Ondansetron is frequently administered intraoperatively, often along with dexamethasone for postoperative nausea and vomiting prophylaxis. Metoclopramide or Reglan affects dopamine receptors and helps the stomach empty, and it is not an effective antiemetic. If you look at the graphic on the far right, there are risk factors and treatment options for postoperative nausea and vomiting. And if you look at adult risk factors, there's things like a history of postoperative nausea and vomiting in the past, motion sickness, female gender, someone who doesn't smoke. If they're given opioids postoperatively, they undergo emetogenic surgery like laparoscopic surgery or ear surgery. Children risk factors include longer surgeries, age greater than 3 years. Strabismus surgery, very highly emetogenic in kids, not so much in adults, and history of postoperative vomiting in children. So if they have these risk factors present and you're considering prophylaxis, there's lots of options. We want to be cost effective, we want to reduce the incidence of this problem postoperatively, and designing an anesthetic that might exclude nitrous oxide, inhaled volatile anesthetics, and postoperative opioids, and use TIVA-based techniques such as propofol or regional anesthesia, and using antiemetics such as dexamethasone and ondansetron combinations. And if prophylaxis fails, using an antiemetic from a different class, maybe one of the compazine-like drugs could be used, but you're not going to repeat dexamethasone or scopolamine, and you're not going to administer metoclopramide to a patient who's had ondansetron intraoperatively, who's having problems postoperatively. The gap from 2014, number 3, was that controlled hypotension during embolization of an intracranial arteriovenous malformation reduces blood flow through the AVM and allows for more controlled placement of an embolic material. The concept being that if you're working up in interventional neuroradiology and they're going to inject this fast polymerizing liquid agent to plug these AVM vessels, arteriovenous malformation vessels, if you can reduce flow through them during the time that they're injecting, there's less chance that it will just go straight through this fast polymerizing liquid agent and reduce the embolization of that medication. So Valsalva can reduce blood flow. controlled hypotension during this time of injection of the polymerizing liquid agent are used during AVM interventional procedures. Gap number 4 was a statistical gap in knowledge, and it had to do with the adjusted odds ratio determining the effect size in a multivariate logistic regression model, which is a lot of words that I can understand why it was confusing to many people. Let's briefly go into this topic. At the far right is a table showing multivariate regression analysis for predictors of in-hospital mortality. So this was basically saying if a patient has X, be it high-risk surgery or ischemic heart disease, what's their chance of dying in the hospital? And this associations were looked at in a multivariate model to see which of the variables were predictive of in-hospital mortality. And you can see that your ASA physical status 4 or 5, if present, statistically is associated with in-hospital mortality, as you would think it would be, as compared to an ASA 1 or 2. But the adjusted odds ratio was almost 4, which is quite high. As opposed to, for example, the Apache 2 score, which the p-value was significant, but the adjusted odds ratio was not that high. So you would say, aha, ASA 4 or 5 had a much higher odds ratio than did an Apache 2 score. So statistical significance is determined for each of the independent variables in a model, as it was here, the p-values for each of these variables. The odds ratio is the measure of association between exposure and an outcome. Exposure being emergency surgery, for example, and an outcome being in-hospital mortality. Effect size is the magnitude or size of an effect and is calculated as the mean of the experimental group minus the mean of the control group over the standard deviation. And if it's like 0.1, we say that's small, 0.3 we say it's medium, and 0.5 we say it's large. Just because something's statistically significant doesn't mean that there is a lot of clinical significance. And for example, if you have a huge sample size, you might reach statistical significance for something, but in reality, its effect size is not very large. And effect size tells us about the strength of the statistical claim, as does the odds ratio. Therefore, using the adjusted odds ratio helps us know about the effect size in a multivariate logistic regression model, such as the one shown here. Number 5 gap was the sodium concentration of lactated Ringer solution is 130 milliequivalents per liter and therefore is less than that of plasma. Most patients' sodium is greater than 130. Comparing lactated Ringers versus 0.9 normal saline, you can see that lactated Ringers has calcium in it, while normal saline just has 154 milliequivalents of sodium per liter and 154 milliequivalents of chloride per liter, lots of chloride. And the milliosmoles is 308, which is above the normal osmolality of plasma, which is somewhere around 280. If large volumes of saline are administered, there's lots of chloride administered. Chloride reduces the strong ion difference, all of that extra chloride. Water dissociates to hydrogen ion, and you get hyperchloremic metabolic acidosis. Lactated Ringers does not have as much sodium. It only has 130 milliequivalents per liter. Its chloride is closer to that in plasma, 109. It has some potassium in it and also has some calcium in it. And lactate is also present. Lactate is metabolized in our bodies, assuming we have a functioning liver, to bicarbonate. And the milliosmoles of lactated Ringers is 275, which is near isotonicity of the body. Knowing the difference between what's in lactated Ringers and normal saline is the gap in knowledge that was present in 2014. The sixth gap in 2014 was related to the hypercoagulable state found during pregnancy, and that increased fibrinogen levels contribute to this hypercoagulable state that we see during pregnancy. There's always a balance between fibrinolysis, or breaking down clots, and forming clots, or coagulation, and it is shifted towards coagulation in the pregnant patient. They're getting ready for blood loss during delivery, and your body physiologically is preparing for that. The hypercoagulability is mainly thought to be from increased factor VII as well as fibrinogen, and this was the gap, not knowing that fibrinogen levels going up during pregnancy contribute to this hypercoagulable state. Gap number 7 had to do with reading cervical films, in that the cervical levels on an AP radiograph of the neck can be determined by identifying the vertebra associated with the first rib, and that which has the first rib is the first thoracic vertebra. So looking at the graphic on the bottom left, I put in a big blue arrow pointing to the label to the first rib. You trace that over and also see that T1, thoracic 1 vertebra, is right there. So look for the first rib, that's T1, the one above it is C7, and you can count up from it. On the bottom right is a lateral x-ray, again showing T1, although in this situation it's hard to see a rib coming off of it, but C7 being right above it. So look for, on AP films of the neck, the first rib, and that is T1, which it is coming off of. The eighth gap in knowledge was related to TEE and myocardial segments supplied by which coronary artery. And the gap was that during TEE evaluation of myocardial function, that the mid-esophageal two-chamber view allows imaging of the region of the ventricle perfused by the right coronary artery. Now, the right coronary artery is represented here in this tannish color throughout the different views that we normally use during TE evaluation. Look at the four-chamber, for example, and you can see that part of the septum and part of the right ventricle is perfused by the right coronary. And then if you look at the classic bouncing donut view, or short axis view of the left ventricle, mid-papillary, you can see that the inferior wall is supplied by the right coronary. Now, if we look at the two-chamber view, which was asked on the in-training exam, you can see that the inferior wall is on the left side and the anterior wall is on the right. Anterior wall supplied by the LAD and the inferior wall by the right coronary artery. So on this two-chamber view, it does allow imaging of the region of the left ventricle, the inferior wall, which is perfused by the right coronary artery. Remember that the circumflex, which is this kind of salmon-colored pinkish, supplies the lateral wall. The ninth gap was that neuromuscular blocking agents don't effectively treat myoclonic reactions or muscle contractions in patients with myotonic dystrophy. Myotonic dystrophy is just one of the many muscular dystrophies that are present, and the muscles contract, these patients that have myotonic dystrophy, with delayed relaxation, and this is myotonia. And so they can have these contractures that are so tight and the muscles don't relax, and they impede their ability to ambulate and to do much of anything. The disease is in the muscle itself, as opposed to myasthenia, for example, or Eaton-Lambert, where the disease is at different locations in the neuromuscular junction. For example, myasthenia is a post-junctional receptor antibody issue. There's antibodies against the post-junctional acetylcholine receptors. While Eaton-Lambert is a pre-junctional issue where you don't have release of acetylcholine normally. Now, the anesthesia management of these patients with myotonic dystrophy, one is that we should avoid succinylcholine. Why? Because when the muscles are contracted, fasciculate, that is, with succinylcholine, it can produce generalized myotonia, where even the muscles of the larynx can spasm and stay shut and not relax, cause laryngospasm of the chest, cause difficulty ventilating, masseter, opening the mouth, and mass ventilation, intubation, and ventilation can all be difficult. These patients are not more susceptible to MH, but we're still going to avoid acetylcholine. Avoid hypothermia, because if they get cold and shiver, their muscles can contract and not relax. Their pharyngeal muscles can be weak and the risk for aspiration. Non-depolarizing neuromuscular blocking agents like rocuronium are not contraindicated, but are often avoided because the patients are already weak. But in the gap in knowledge was that obviously some believed when they took this exam that if a patient had a myoclonic reaction, they could relax that muscle with a neuromuscular blocking agent like a non-depolarizer. And the answer is no, it doesn't work well because the disease is in the muscle itself, not at the neuromuscular junction. And rocuronium will not relax those muscles. Patients often have heart block or have myotonia dystrophy, and pacing equipment should also be available as a side note. Gap number 10 was that ingestion of water 2 hours preoperatively does not cause a decrease in gastric pH. Our fasting guidelines, as you know, allow clear liquids up to 2 hours before surgery, breast milk up to 4 hours, non-human milk formula would be 6 hours, a light meal 6 hours, and a regular meal 8 hours. And allowing someone to have water 2 hours preoperatively is not going to increase the volume or dramatically change the pH of their stomach, and does not put them at risk for aspiration pneumonitis. The last gap in 2014 was about ventilated patients and ventilator-associated pneumonia. And the gap was, in ventilated patients, sucralfate is superior to an H2 blocker in preventing ventilator-associated pneumonia, or VAP. And proton pump inhibitors actually increase the risk of ventilator-associated pneumonia. Now, ventilator-associated pneumonia is a type of hospital-acquired pneumonia that develops 2 to 3 days after endotracheal intubation during mechanical ventilation. And in ICU patients, we're often worried about stress ulcer development, and we want to prevent that and prophylax against it. Sucralfate coats the ulcer. H2 blockers will decrease stomach acid, and potentially bacterial overgrowth can occur with regurgitation and aspiration possible. So what do we do in an attempt to reduce ventilator-associated pneumonia? At the far right, it shows several things. One, put the head of the bed to 30 to 45 degrees up. Sedation vacations and assessment of readiness to wean, DVT prophylaxis, stress ulcer prophylaxis, subglottic secretion drainage. There are endotracheal tubes made that have special cuffs and ways to drain above that cuff and put it to suction to remove secretions that could potentially go down and around the cuff and into the patient's lungs, and daily mouth care with chlorhexidine. So again, the gap in knowledge in this case was that proton pump inhibitors actually increase the risk of ventilator-associated pneumonia. If you want to listen to and view the gaps in knowledge from 2016 and 2015, they are on separate podcasts, and I hope you have a great day.